Assalamu alaikum wa rahmatullahi wa barakatuh. Very good evening and welcome to another edition of Health Matters. I'm Khawa Solomon and myself and my team will be with you for the next hour, so stay with us as we unpack breast cancer. It is October. Did you know it is Breast Awareness Month, October month? The awareness is just to create that conversation, to get that information out. But it's whether it's awareness for breast cancer, colon cancer, and we're going to get to that. We're going to get to men's health as well. So look forward to that in the next couple of shows as well. So it's the conversation that needs to start, not just in October, but the rest of the 365 days in the year. But today we focus with our specialist in studio, as well as Dr. Shaida Umar, who will give us a brief introduction quickly on October Breast Awareness Month. Dr. Shaida.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, but as Khawa, my learned presenter, has articulated, it is something of a very sensitive nature, and I think something that no woman wants to hear. You have breast cancer. I think that is something that everybody is terribly petrified and afraid of, and we know that 1 in 8 women are likely to develop some form of invasive breast cancer. So I would just like to state something from the Holy Quran, where the Quran speaks and Islam speaks about protective measures and how to avoid. I mean, it's a risk of developing breast cancer, but something that could assist. It's not a definite, but it speaks to breastfeeding infants for at least 2 years. And this recommendation was revealed to us long before any medical or technological advances discovered the innumerable benefits that nursing has on the mother and child. The Quran states, mothers may breastfeed their children 2 complete years for whoever wishes to complete that period of nursing. Upon the father is the mother's provision and their clothing according to what is acceptable. No person is charged with more than their capacity. No mother should be harmed through her child and no father through his child. This proves to us that the Quran, through God's infinite mercy, has not only provided a provision for the dependent newborn, but also a shield for the mother. This is not to say that every breastfeeding mother will be completely inoculated from the disease, but it does add a substantive preventative measure. As the Quran says, never will we be struck except by what God has decreed for us. He is our protector, and upon God let the believers rely.
Absolutely. So beautiful to start just also with the status of women and mother in that regard. Dr. Shaida Umar, my co-host for this evening, as well as our in-studio medical specialist, head of Teddy Bear Foundation. But let's welcome our guest for this evening, Dr. Navashni, who is our breast surgeon based at Bara, and Dr. Omande Ogede. Ogudi.
Yes.
I need to get my O's and my R's right.
Okay,
He's based at Santon Oncology Unit, as well as Ahmed Kathrada in Lens, our specialist, medical specialist, medical oncologist, as well as breast surgeon. Thank you so much, guys. So we've got a big title ahead of us here, and definitely want the viewers to interact with us with any questions, queries, comments, interactions we want from our viewers, from you. If you've been infected or affected by it, your family member, a friend, a colleague, and I've been also introduced to a beautiful, matured lady in the community in Johannesburg, and I look at her every week when we see this auntie. She's so strong, so willed to keep going, and she goes for her therapy, her sessions that she has to have, and she has off and on days. But whenever you see her, I'm just thinking of her right now, talking about this topic, and there are these beautiful ladies and women that keep going, and they keep going. But first, let's just establish the introduction to the medical term of breast cancer. Either or.
Ladies first.
Okay.
Dr. Navashni.
Well, breast cancer is it's a sort of encompassing definition of what we actually deal with, because you have different types. You have the early type or the pre-invasive type, and then you have the invasive breast cancer, and how we approach it from a medical point of view is different. So I think the definition of it is important as well. What it is essentially, from a layman's point of view, is when something in your genetic makeup goes wrong and the cells within your breast start developing abnormally, and then you have this early growth of what we call a tumor or a cancerous growth. And something I think that Dr. Ogude appreciates very well is, specifically with breast cancer, is right from the onset there's the risk of it starting to spread. And we are coming to recognize more and more that it's not just a disease in the breast, but it's a systemic disease. And it's important to realize that when you're treating it as well.
Dr. Gude, from your side, is it only women that suffer from breast cancer?
It's funny you asked that, because that was one of the first comments I was going to make.
Okay.
Look, it is largely a female issue, and I don't think we should lessen that, because that's really what it is. But I think we should also not forget that it is. We do find, upwards of about 2 to 3% of males who do develop breast cancer.
Sure.
So it's not something to be ignored. And, there's a stigma as well, I suppose, that comes with, for whatever reason, for being male and having breast cancer. So it is important for males who do find abnormalities just to be aware of it. But by and large, it's a female issue. And it's important for most females to be very aware of themselves and their breasts. Screening, as Dr. Marigan was saying, that, as soon as this thing develops, there's a risk of spread. So, one needs to be aware as early as possible. The earlier you get it, you pick it up, the earlier you can deal with it. So I think really this is the message and the awareness we want to create around breast cancer and Breast Cancer Month.
Sure.
So you asked, you stated something very, very important. You said the earlier it is picked up, the earlier it is detected. What would you recommend? At what age should people start looking out and examining self-examination? And when should these self-examination techniques be transferred to the general population?
Right. Yeah, so I think it should start fairly early. I think when, women become of age, 18, 20 or so.
Okay, so
I think just
that's the age cohort that one should start already looking at.
Yes. So I think, and it's really trying to create awareness about your own body and about your own breasts, and, so that you can be, pick up when something goes wrong. You can only know when something's wrong if you're aware of yourself and what you're like. So I think it's important to, regularly do self-examination, softly use the palm on both sides, and just be aware of one's breasts. It's also important to know that we do pick up breast cancer in younger and younger patients these days.
I wanted to ask you that. What is the youngest age where you've picked up breast cancer?
Breast cancer. Personally, most recently, I think the age was about 25.
Oh, sure.
And
So I've actually seen somebody at 22 that we initially thought had a benign breast lump, and when we excised it, it was found to be a malignancy. So although, in terms of the age that you would start to worry, remember something, benign breast disease is also very common. So things like fibroadenomas are extremely common in the very young, and they present as breast lumps. But when there's something atypical or something unusual about the presentation, then it needs to be investigated, because you could easily be dealing with a cancer and you're assuming you're dealing with a benign lump.
But let's explain that for those who are not aware, benign and malignant.
So benign means non-cancerous, so without the potential to spread. And we often manage benign lumps like fibroadenomas, small fibroadenomas in young patients, conservatively or non-operatively. So we confirm what it is, and we reassure them that it's very common and it does not turn into a cancer, and you manage it by surveilling it or watching it and see what happens. You don't have to cut out every breast lump in every patient, especially the younger ones. But the important part is that we need to confirm what we're dealing with before that happens.
All right, we need to take a short break. We'll come back, and time really flies. So we'll try and get as much information on breast cancer. And I know there's always more to talk about, but your interaction is also important. So please do call us on that line, which will show on the screen just after the short break. Stay with us. Assalamu alaikum, a very good evening, welcome back. October Breast Cancer Awareness Month, and that's what we're talking about all of this evening. And please do join in. We want your comments, questions and queries. With me in studio is a medical in-house specialist, Dr. Shaida Omar, as well as our breast surgeon. So we've got the best of the best lined up. All the questions can be answered and dealt with, so please do call in with your breast cancer question. And I know the big question behind everybody, which we were just chatting about now, Dr. Omar, was, is it in my family? What happens if it is? Is it always coming from that? But we're going to get to that in a minute. We're just going to quickly talk about the examination. But before we do that, I want to touch on to something that you, Dr. Mandi, mentioned of 18, 20, picking it up at 25, 22. It's really scary. So talk to us about the understanding of having it self-examined and when do you go for the memo?
Right. So I think what's important, with self-examination, and I think what's important to emphasize is this is about self-awareness, okay? So to know your own body, so to be able to pick up when things do go wrong. So whilst we've seen younger patients, these are by and large the exception. So this is not the norm. Most patients are well over 40 and generally in their mid-50s, but you do get younger patients. I think the message here is be self-aware. Okay, if there's something that you're worried about, consult your doctor, and then you can get the appropriate sort of recommendation in terms of study. You can either be reassured or move on, but it's better to be safe. Rather than, what happens often with the younger patients is that they're dismissed and they come in, they've got a lump, and if it's potentially cancerous, even health practitioners will say, oh, no, it's not.
We've got a slide up now of something that looks like a normal and abnormal nodule. So is that something that you would feel during your breast examination?
So sometimes you might have a very small lump that you can't actually feel. And if you do a mammogram, so if you look at this one, for instance, this looks like a small lump in a large breast. You may not necessarily feel that, but you would pick it up if you did the scan. And then what would happen is the radiologist would decide how concerning it was. They have their criteria to assess on the scans, and they would then decide to do an image-guided biopsy. So using an ultrasound, they would biopsy even a small deep lump. So we've got quite significant advances in terms of our diagnostic.
Yeah, this is a 3D, so this is quite an intense picture, is it?
So this is something called a 3D mammo or a tomosynthesis mammogram. So again, it speaks to the advances that we have in imaging technology, where if you look at it, it just looks like a bunch of white spots. But a radiologist, a specialist, would be able to pick up something suspicious in all of that and be able to biopsy it. So
is this the same boob? Is this the same breast? Two different breasts?
So this is the right. This is one breast. It's the one breast where they're actually they're focusing in on something that's worrying, and then they would be able to get to that.
Very
I think what's important to remember about imaging as well is that you have to be of the right age. Mammograms, generally we reserve for those above 35, and generally above 40 actually. And the reason for that is that the female breast changes as one ages. So it becomes less dense and you get more fatty tissue inside. And when there's more fatty tissue, you're able to pick up better a malignant lesion on a mammogram. Whereas with younger females, it becomes a lot trickier, such as in that breast actually, it's particularly dense. So it's easy to miss things. So it's important that you get the right imaging as well. At the right age. And so an MRI, for example, is also used in patients where you have very dense breasts, so it's more difficult to see, or they're younger. And this gives us, a better delineation of what's happening in the breast.
And particularly for younger patients, so younger than the age of 35, even if there is a lump and we're worried, ultrasound is actually a very good investigation where you're able to pick it up and you're able to biopsy it. And only if it's confirmed to be a cancer do we follow up with the mammogram, because you know that mammogram, there's drawbacks in younger patients with dense breasts.
Dr. Ugude said something very important. You spoke about the density and denseness of the breast. So for women that are on HRT, doesn't it affect the density of the breast as well?
Not specifically, no.
Okay.
So remember, HRT is typically used for postmenopausal women, so women that are older, and their breasts tend to be less dense and more fatty. And so you would do a mammogram in a patient that's older. So HRT, not specifically.
HRT?
Hormone replacement therapy.
Okay.
Yeah.
I'll probably get there.
Yeah. What's important about hormone replacement therapy, though, is that there has been, I think, reasonably good evidence saying that there is an association with an increased risk for developing breast cancer, especially if you use it for a period of greater than 5 years. So that's the main issue with hormone replacement therapy.
So you've talked about risk here. So if we can look at the incidence, would both of you, I mean, just looking back historically, going back in time, the prevalence, the incidence and prevalence of breast cancer, would you say there's an increased incidence, or is that there's greater awareness and more diagnosis are being made now, and that people are able to come forward because of the awareness that is made?
Look, I think it's definitely a bit of both. There is a definite increase in incidence, but there's a definite increased awareness, which is a good thing. So we're picking up more breast cancers and we're picking them up earlier, which is what we really want to do. That's what screening is about, to be able to pick it up early and to be able to deal with it definitively and successfully, being able to save lives.
So for the viewers out there, I think the awareness, we talk about self-examination. Would you be willing to actually demonstrate the self-examination? Because I'm not sure that everybody actually understands.
Sure.
We're visual people, so we want to see if you could.
I think I could describe it.
Yeah.
Okay, please.
So if you're speaking about self-examination, and I teach my students this, in fact, and how they should be examining breasts as well. For a woman that's examining herself, what we recommend is try and not do it too often, right? So you should do it maybe once every 2 weeks or once a month, but not daily. When you're examining, you can do it in the shower, for instance, or in the bath. What is recommended is that you don't use the tips of your fingers, but rather the flat of your hand, because if you use the tip of your fingers, everything's going to feel like a lump. So the flats of your hand, you place the one hand underneath and the one hand on the top. And remember, your breast tissue extends all the way up to your collarbone. So you should examine all the parts of your breast, and if you lift your hand up, it'll allow you to examine the part of your breast that goes up into your armpit. And remember, picking up a breast cancer is not just a lump in the breast, but also a lump in the armpit. So it's important to check as well.
So lifting up your arm.
Lifting up your hand, examining all of your breast, including the tissue that goes up to your collarbone, and using the flat of your hands, not the tips of your fingers.
We seem to be talking about lumps all the time. For people that have experienced where there's oozing from the breast, one breast,
nipple discharge.
Nipple discharge, and sometimes pain. Can you explain that or speak more to that, please?
Sure. Look, I mean, typically what happens is when a woman comes, they will come to a general practitioner or a clinic or a breast clinic, for example. And there's various ways that they can present. I think one of the commonest things we see are women that come with pain. And a lot of the time, that's probably the least concerning symptom, because most pain is normal or physiological. And it might be hormone related, or it might be referred pain, like you have an underlying inflammation of your rib or something like that. But we will obviously take a proper history, we will examine, and we will decide if further imaging is necessary, like a mammogram in an older patient. Some of the other symptoms would be things like skin discoloration or changes. Those we worry about a little bit more. If you have a spontaneous nipple discharge, that's especially if it's bloody, that we worry about a little bit more. And obviously the lump in the breast or the armpit, and then things like puckering of your skin where it looks like it's starting to dimple from the inside. So anything that looks a little bit funny, all of those, you need to go see a health practitioner.
So I think before you even start examining your breast, I think it's important to just look in the mirror and have a partner or somebody else also look and just see if there's any abnormalities. Has the skin changed? Has the color changed? Does it look redder than usual? Is it, the skin pulled in? Is the nipple inverted? Is it pulled inwards? Okay, so they're small little signs before you even touch the breast that you can pick up abnormalities. Yeah, sure.
We want to talk how it started. Where does it come from as well? We touched on a little bit at the beginning, so there's this build up to that. More on breast cancer awareness just after this. Stay with us. Assalamu alaikum. Welcome back. This is Health Masters. Breast cancer awareness is a topic of discussion for the entire month of August, so get that conversation going. Wear your red ribbon, pink ribbon. That's I didn't realize I was wearing pink today. So, Dr. Ahmad, looking at we've got a caller online. Please do call in. Remember to turn down your television set so you can hear us. This is Health Matters. Very good evening. Assalamu alaikum.
Wa alaikum.
Yes,
I
ma'am.
just want to find out how long must you be on tamoxifen when you are a breast cancer patient?
Okay. Thank you. Shukran for your call. All right. We'll just deal with that caller first.
Okay, sure. So tamoxifen, what the caller is talking about is basically one of the drugs we use to treat and manage breast cancer.
Okay.
Depends on what it's being used for. Sometimes we use it for pre-malignant cancer, where it's still not developed into a full cancer as a preventative measure. Mm-hmm. And then in those who have had some sort of treatment, often they've had surgery already, and we're trying to, it works as a safety net to pick up small cells that might have leaked from the big cancer and to prevent the cancer from coming back. And this really depends on how advanced the cancer was at that stage. So we tend to say earlier breast cancer, anything sort of less than stage 2 or less will require tamoxifen for about 2 years. And the idea with tamoxifen is that it cuts down the estrogen that often drives the growth of the cancer. This is why things like hormone replacement therapy, the oral contraceptive pill, drive growth in cancer, or at least can be risk factors for that. For patients who have higher risk cancers, they can take it for up to 10 years. And those who've had cancer that's spread, this is essentially indefinite, and they can have it lifelong. So it really depends on the stage, is a short answer.
Thank you. Some medical questions there. Now, Dr. Ahmad, we were discussing in the break of risk factors, and you've mentioned the breastfeeding bit.
Yeah, we said that could be a protective measure, but we know that there are many risk factors that contribute to the high incidence of breast cancer. We know that in some families there is a family history where you find a number of members of that family, and intergenerational patterns, you see that they've been plagued with breast cancer. Perhaps both the doctors here, the learned scholars on breast cancer, can elaborate more on the risk factors, which I think is very important for us and the viewers out there.
Well, there are a number of risk factors that we, when you speak to a patient and you're taking their history, you try to establish if there are specific risks with this patient having a cancer. Some of the high risk factors would be things like a family history. So especially you would worry about patients that have one or more first-degree relatives, so mother, sister, daughter, father, son, that have had breast cancer, and especially if they were diagnosed before the age of 50. Then you worry that there might be this genetic inheritance, the BRCA mutation, for example. Then in patients that have had a previous history of breast cancer themselves, they are at increased risk of developing another breast cancer. So that's a very strong risk factor. And then if you speak about things that may be protective for breast cancer, so breastfeeding, yes, is protective. And especially if a woman breastfeeds and then gradually weans off the breastfeeding. So in terms of the changes that happen in the breast, it's a little bit more gentle, so to speak. And also pregnancy, especially pregnancy at a younger age, socioeconomically obviously is not ideal, but is supposedly protective.
Younger than 20?
variable. So what happens is, if the younger you have your first pregnancy, there's about a 10-year gap after that where there's a slightly increased risk of having a breast cancer, and thereafter it's protective. Yes, so the later you have your first pregnancy, the greater the risk of developing a breast cancer. And obviously women that don't have children and don't breastfeed, there's a slightly increased risk.
So I want to ask you, you're saying risk factors. What about contraceptives, oral contraceptives?
Yes.
So all contraceptives are definitely a risk factor. Increased estrogen exposure, we know, is a risk factor for breast cancer. Hormone replacement therapy is a risk factor for breast cancer. But I think what's important about risk factors to remember is that none of them in of themselves will either protect you or lead to cancer. Okay, each of them are weighted differently. It also depends to a large extent on your genetics. So every person has a threshold, and this threshold, will depend on the risk factor. You're tipped over. Okay, so I don't think the message should be that any one of these things can prevent or lead to cancer. So if you've never had kids, we're not saying go out and try and have, we have people who've developed breast cancer that have 5 or 6 kids, and the opposite is also true. So the important thing is, what can you do personally, and just be aware of the risks, So if you don't have to be on oral contraceptive pill, what are the alternatives you can discuss with your gynecologist, intrauterine devices, things like that.
So I'm going to throw you a curveball. Okay. What about stress? The factor of stress and diet.
Well, I think more and more there's a lot of research about other factors that may contribute, like your lifestyle, the lifestyle factors. So things like having a too sedentary lifestyle, not exercising, obesity, increased abdominal girth, smoking, chronic alcohol use, possibly even stress. So while there's no, level 1 evidence saying that there's a direct link, there certainly seems to be an association, and we're learning more and more about it all the time. So I think
it's interesting how the medical doctors, do refer to stress as a possible, a trigger, and yet every doctor that we've had on the show will argue stress is not a factor for causing. It might be in addition to sort of, make it worse, but stress always comes up. But for some reason, there isn't that. It's stress. I
think there's a definite association, and I think with a lot of malignancies, it's been shown that even relationships that you have, how happy you are, how many friends you are, and these connections in community are important. They're protective. So I think it's we feel that these are always soft things, and they're not as scientific.
They do have a bearing, because if you look at the cortisol levels,
that's what
explain.
It's less tangible.
It's less tangible. You can't put your finger on it exactly, but I think there must be an association. Stress causes a physiological reaction in you, and you know that a cancer, something goes wrong physiologically. So.
And the brain makes the body work.
Yeah, sure. And it drives the cortisol levels up, which
the cortisol.
And we know that that's definitely a risk factor. We know if you're nervous about something and you're about to do a speech or write an exam, you can induce diarrhea and all sorts of things in yourself. But simply just thinking about it.
It could be a combination of factors that could, of course.
Well, that's exactly what it is. So that's, even with the risk factors, it's about painting the whole picture. It's not just one specific thing.
But you also beautifully articulated the protective factors. It's not just one thing, it's a combination. It's a whole lifestyle and holistic approach to preventative measures.
Understanding that if you're on the pill and you can go another route, do that. If you've got it somewhere in the family. I want to talk about that somewhere in the family. And it's celeb cases you hear about, this woman having, found a test and then she's going sort of breast out. Does it happen in real life? Tell us about that scenario.
Sure, I think we do see patients with what you're referring to is Angelina Jolie and the BRCA situation, and that brought a lot of attention to...
And BRCA being the trigger, the gene.
Yes.
Breast cancer
Gene.
So it's a driver gene that makes cancer grow. So the patients with these BRCA genes have a risk of not only breast cancer but ovarian cancer. And you know, you're looking at well over 80-90% of these patients developing breast cancer or an ovarian cancer at some point in their lives. But I think it's important to remember BRCA genes are actually quite rare. Most breast cancers are what we call sporadic. So they're not necessarily related to that single genetic. And
about 90% of breast cancers actually are sporadic and not genetic.
So her case specifically, she went for the test, found the BRCA gene.
So she had a family history, a significant family history. Her mother was diagnosed with breast cancer. So she decided to test, and she did not have breast cancer. She just had the mutation that could have resulted in her getting a breast cancer at some point in her life. So her risk was significantly higher. So she had risk-reducing surgery.
And medically, what is your response to what she did?
It's appropriate, you know, especially we don't recommend risk-reducing surgery for every patient off the street. But obviously in the patient that's tested for the BRCA gene and has tested positive, it has to be it's not an easy decision to make. It has to be in combination with the genetics counselor and the various people involved, because you're embarking on big surgery.
And I was going to say, no surgery goes without any side effects.
Absolutely.
No, this is true. And if you're going to consider removing or doing a preventative surgery to remove your breasts, you need to consider it for your ovaries, and that has a lot of implications. You know, premature.
Because you hear about it in the news and it's in the tabloids, and you think it's just some sort of hype. So we have some proven.
Look, it's well documented that it's a reasonable approach to consider this risk-reducing surgery for this particular group of patients. That's the important bit to understand.
We're going to talk about treatment and some of the danger signs. Heard about painless lumps in the breasts and people living with breast cancer not knowing it. We'll talk more just after the short break. And remember, we're taking your calls as well. Back in a moment. Assalamu alaikum, welcome back. Our last few minutes as we tackle breast cancer awareness for the month of October. And remember, this is just not for this month. We are highlighting it for this time being, but keep that conversation going and regularly, as they say, have that self-examination from a very young age as well, like 20 plus. Ask your GP, visit your clinic. They will advise you. If it's not something that you know and you're afraid to ask, this is important. Google it, go and see your GP, find out, but don't just sit there and do nothing. So in studio we have breast surgeons based in Bada, Dr. Navashni, as well as oncologist, medical oncologist, Dr. Ugude, in Lens, in Santon and Ahmed Kathrada Hospital. Guys, we need to wrap up, and Dr. Shaida Umar also in studio, looking at the sort of way forward, the treatments, and some of the danger signs that people are literally walking around with lumps, not checking, not knowing, and that might possibly be cancer. So let's talk about the painful lumps and treatments as well. Sorry, painless lumps.
Painless lumps, I think most of the lumps we see for patients who present with cancer are generally painless. And I think this is a lot of the misconception that's around that if you have breast pain, it's going to be cancer, and often it's the opposite. It can cause pain, but by and large, breast cancer initially when it presents with a painless lump, and some of the other signs that we've spoken about. So beware of painless lumps as well. These must be taken seriously, even more so sometimes than the painful lump.
Either or must be checked out.
Yes.
Dr. Navashi, on your side, what is the way forward with treatments? What happens at stage 4, stage 1, 2? I know we're going to press it into
Look, if we obviously, when we see a patient, we determine what to do. We investigate them, we diagnose them, and we stage them. So then we know whether they're early staged or advanced or metastatic, and that's when the cancer has spread. And yes, the treatment is different for all the stages. So typically for early stage, we tend to start with surgery as the first treatment. And remember, there are multiple treatments. There's surgery, there's chemo, there's radiation, there's hormone treatment. Right? Those those are largely the main treatments. And in the early stages, we start with surgery. And there's different types of surgery. So it's not all mutilating mastectomy surgeries, although sometimes that's necessary. But there's also breast conserving surgery, where in the early stages you're able to cut the cancer out and preserve what looks like a breast, and then the patient then goes for the further treatments. So surgery is an important part of it, as are the other modalities. But like I said, for the early breast cancers, surgery is typically what we start with. Then for the more advanced cancers, I think Dr. Agude has his speciality.
You said something about surgery, and you said, removing excision of the lump.
Yes.
Sometimes you find patients actually opt to have mastectomy.
Yes, absolutely. So very much it's the patient's decision. And while you advise them on the different options and what the possibilities are, you always respect the patient's decision. But it's the patient's body. So if the patient chooses to have a mastectomy, you have to respect that. And it's a viable treatment option, where essentially you are, and look, there are different types, and you can have reconstruction after your mastectomy. So, there are many options for patients, and it's usually discussed with all the role players. So the plastic surgeon.
Consider that as well as a preventative measure if the patient opts for that.
So you mean if there's no cancer in the breast?
Right.
Look, again, that's a little bit controversial because surgery is surgery, and if you're going to have surgery, there should be a good reason for doing it, and you must have a well-informed discussion with the patient about what the risks are, what the benefits are. You respect the patient's wish, but again, as the clinician, I think you're obliged and you need to be responsible about what it is you're doing.
Dr. Agude, your extreme measures?
Yeah, no, sure. Look, I think it's important to say, there's options, and there's not only one way to do things. Apart from just choice, I think it has to be done within the context of information. Okay, so breast conserving surgery, I think the studies have shown are really no different than a mastectomy, provided that you have radiation with it. Okay, so it's all about weighing up the risk factors, and sometimes you will always, some patients need radiation no matter what happens, and in that case you might as well try and save your breast if you can. But if the patient feels strongly that they want to have mastectomy, that's also viable, but you have to explain things like if you're having a more extensive surgery and removing the breast, you might have swelling of the arm. Okay, so these are all the things that you have to have a discussion about. So you need to ask all the questions. Okay, you need to go home, discuss with your family, come back and ask your doctor more questions. And usually this is done also by the doctors usually speak within a forum, what we call a multidisciplinary meeting, where we discuss these issues and formulate a plan for the patient.
So I like what Dr. Agude said about multidisciplinary and psychological help.
Absolutely, and that's actually where I wanted to start, Dr. Navashni. Your wrap-up message, not just about the patient, but the family involved in.
Look, I mean, from our experience, it's not just a disease that affects one person, it affects a whole structure. And a lot of the time, like you said, it largely affects women, it can affect men, and it affects the center of the home, in terms of women's health. And it's not just a diagnosis of a cancer, there's a lot more to it. It's a psychology, it's a woman's impression of what it's like to be a woman. So I think there's many things to consider, and it really should be managed by a multidisciplinary team.
Dr. Agude, your take-home message to our viewers for now.
Okay, I think it's important to be aware of your breasts, get screened early. If there's anything that you're not comfortable with, see your GP, see your specialist, okay, and get it checked out. Get as much information as possible. Make sure if there's an issue that you see a specialist or a team of specialists that generally deal with this kind of thing every day and are able to help you in a holistic way.
Thank you so much, guys. Dr. Agude and Dr. Navashni, a pleasure having you. Hope to see you soon as well. And Dr. Umar, your 30 seconds quickly as we wrap up.
Just getting help, getting the professional help. Consult. When in fear or in doubt, just seek the professional, get the expert.
There we have it. Thank you so much to our panel. Breastfeeding Awareness Month, October. Keep that discussion going wherever you are. Just bring it up and wear that pink ribbon. From myself, Hawa Solomon, wassalamu alaikum, and goodbye for now.